INR, International Normalized Ratio. Since the introduction of prothrombin time in 1935 by Quick, and it's the mainstay of monitoring patients with anticoagulation therapy. The prothrombin time is relatively simple in concept, consisting of recalcification time of a patient's plasma in the presence of a powerful tissue procoagulant extract called thromboplastin. Originally, thromboplastins were extracted in daily basis from cadaver human brains. However, in 1950s, commercial supplies from thromboplastin became available. Commercial thromboplastin, sure, it's more convenient, and theoretically it's supposed to bring more accurate result due to standardization. Commercial reagents were from various animal sources, which are contaminated with clotting factors. This has resulted in two consequences. First, since it's contaminated with clotting factors, it leads to lower response of thromboplastin, which encourage to give patients higher doses of anticoagulation, which result in a more incident of bleeding. Second, because of its different animal sources, it gives different results. That leads to a different prothrombin time result in different laboratories, as they are using different reagents. This problem did not come into clinical notice till two studies published in 1982. The first is in the British Journal of Hematology, and the second was in the New England Journal of Medicine, where both demonstrated that patients in different geographical areas require different doses of anticoagulation, and that was simply due to different reagent used. In 1983, WHO, World Health Organization, adopted INR, International Normalized Ratio, in an attempt to standardize the coagulation lab results among different reagents. Concept of INR. INR is a trial to remove the effect of variation of reagents used on the actual test of prothrombin time. The equation states that INR is equal to prothrombin time of the patient divided by prothrombin time of the control to the power of ISI. Prothrombin time of the patient is the actual result detected or recorded by the lab machine. The prothrombin time of the control is the same laboratory control result. ISI is the International Sensitivity Index. The ISI will measure the responsiveness of thromboplastin used. The ISI expresses the sensitivity of thromboplastin reagent compared to the WHO reference thromboplastin, where ISI is equal to 1, or it's also called IRP, or International Reference Preparation. Reagents that are less sensitive than WHO reference have corresponding ISI value more than 1, and vice versa. Reagents that are more sensitive than WHO reference have corresponding ISI value of less than 1. In theory, all reagent will give end result exactly as WHO reference, as it's corrected by using specific values in the formula. Let's take this example to illustrate the point that in theory, all thromboplastin sources should give the same INR result. Let's assume we took 3 different reagents from thromboplastin, X, Y, and Z, and we used them for one sample taken from a specific patient. Let's say that the reported patient prothrombin time in seconds in our lab is 18, 22, and 34 consecutively. And the mean normal in seconds is 11, 14, and 12 consecutively. We notice here that prothrombin time is different with different reagents, and also mean normal is also different. The first step is to calculate prothrombin ratio, which is equal to patient prothrombin time in seconds divided by prothrombin time of the mean control in seconds also. And the result of dividing each of these figures is 1.64, 1.57, and 2.83 for X, Y, and Z consecutively. Let's say that one of the reagent is having an ISI of 1, which is the WHO reference, and let's assume it's Z. Then, applying the INR equation will result in 2.83 to the power of 1, which means it's the same prothrombin time ratio detected by our lab. If the INR formula is true in real life, then the result of INR for both X and Y should be also 2.83. That will happen only if ISI of X reagent is 2.11 and the ISI for Y reagent is 2.31, so both will give end result of INR equal to 2.83. Is that what happened in real life? No. Unfortunately, in real life, there is a remarkable disagreement in INR results with different reagents and instruments used, despite the use of appropriate or relevant ISI. Many reasons could be attributed for the INR discrepancies between different laboratories, and here we will discuss some of them. In recent years, there is a trend in using automated or semi-automated instruments or coagulometers. These new instruments or coagulometers have shown remarkable and unpredictable effects on INR. Sensitivity of ISI also play a role. Low ISI human thromboplastin are more affected by coagulometers than high ISI rapid preparations. The higher sensitivity of thromboplastin, the lower ISI. Hence, the precision of prothrombin testing tends to be greater with a lower ISI. Thromboplastin with an ISI between 0.9 to 1.7 are acceptable according to revised guidelines from WHO in 1999. During initial days of oral anticoagulation, INR is not reliable. This is due to the fact that there is a major depression of a single clotting factor, which is 7. Other reasons for differences in INR might include pre-test variables such as sampling or blood collection problems, or incorrect prothrombin time control used. Also, it could be due to incorrect ISI of a local thromboplastin reagent. Also, INR result is not reliable with a patient with lupus disease. Also, results of INR over 4.5 is not reliable.